So for us, it's looking at all these different things when we evaluate patients. It's looking at joint stability, looking at the alignment of the joint, looking at the integrity of the articulation or the joint itself. In some factors like the spine, looking at neurologic issues that may be playing into the whole problem. There was a recent, and actually for this one here, a recent article that was published, and I'll just tell you the title, because this may rewrite the history books in orthopedics and neurology. The title of the paper was Pain Causes Arthritis, Arthritis Does Not Cause Pain. Basically, it was a series of animal models showing that neurologic issues were key in the formation of arthritis. So it's an interesting article. So in talking about stability here, we look at active stability and passive stability of the joint, things like muscle strength and ligament integrity. Talking about the articulation, you've actually got the structure of that, whether or not the joint capsule is intact and doing what it's supposed to do, cartilage, structural bone, and those are spine and peripheral joint applications. If we look at alignment, obviously in the coronal, sagittal, and axial plane, and then neurologic, whether or not you've got neurologic irritation, actual nerve damage, or just nerve sensitization. So here's a good example. When we look at a joint for stem cell treatment, again, it's not about just placing magic stem cells into the joint. It doesn't work, I can tell you, if you just throw magic stem cells into the joint, or at least doesn't work all that well. It's looking at things like this. You've got this normal coronal MRI of the foot and ankle. So you can see here forces would go from here to there to there. Pretty nice alignment. You can see the structure is built to handle that. But here's a patient that shows up for treatment where you've got a ligament that's ruptured on this side. The calcaneus has come this way. So you've got basically forces now coming up through this area. And you can see this dark area in the bone here, that's bone dying off on a T1 MRI. You can see this T2 or stir type image here where you see the bone dying off. So placing stem cells into that joint will help, but it's not going to fix this person's problem. What needs to be fixed, if this person's going to get fixed, is this alignment issue, and then deploy cells. So again, just throwing in magic stem cells is not going to get you there, at least in looking at the joint repair or joint salvage. So again, we would look here at stability, which was the deltoid ligament laxity, the status of the articulation, alignment, and then no problems with this guy's neurologic system. So let's look at peripheral joint cartilage repair with all of that in mind, meaning we look at the whole patient, not just any specific joint, but these are MRI cases before and after. We generally only use a 3 Tesla MRI. There aren't really that many in deployment yet. My guess is in this area there might be 2 or 3 that are being used out of the 100 MRIs that are probably in Las Vegas. So it's a fairly rare type of ultra-high field MRI that we've used for these studies. So here's a good example. This is actually a nurse who was involved in Israeli self-defense class. Now, I'd never seen an Israeli self-defense class, but it is some violent, crazy stuff. She was just beating the snot out of herself on a daily basis. So she got this cartilage lesion. You can see here, here's the femur. This is a special type of MRI sequence where you can see here the cartilage lights up in this type of light color. The bone is the dark color. And you can see here this on the before sequences across the lesion, a fairly good sized lesion here in the cartilage. And then this is after, and you can see some repair of that lesion. We followed this woman, and this is still the way it is now, about 2 years after her treatment. 2 years after her treatment, she's still doing very well. So she's now, I think, about 2 years and 2 months out from her treatment. And realize that this was not surgery or microfracture of this area. This was actually just injecting stem cells via a needle into that hole in the cartilage. This is a woman, a big hiker around our area. You can see here, again, a very similar case. this tibial plateau lesion. So you can see gray cartilage there, a break in the cartilage, gray cartilage. Same thing here. You can see some breakdown of the cartilage there. And then after treatment. Again, still doing well about a year after her treatment. This is a gentleman where we were looking at cartilage thickness. So this is a very unusual type of sequence. And I'm not even quite sure I can get all these initials right. But it's an FSP, gradient recall fast spin sagittal, where you really see the cartilage lighting up like a Christmas tree against the dark bone, and measuring cartilage thickness before and cartilage thickness after treatment. This is an interesting one. This is a gentleman who had a very, very bad meniscus on his in his knee. You can see here, this is sort of a normal meniscus, this nice triangle shape. It's got a few issues on this side, but that looks pretty good for someone in their 60s. But you can see on this side, he's got basically no meniscus left. It's all chewed up. Same thing here, same thing there. And it's so bad at that point that the bone here has got a big hole in it. And bone tends to do this as it gets overloaded. As the amount of forces on the bone increase, the part of the bone that's getting forces on it tends to die off, and you tend to get these holes. So you can see here on the after picture, he's got his meniscus looking at sort of a different shape. But, we might say to ourselves whether or not that did anything functionally. His pain went down. But you can see here, we don't see this big hole, but let's look at it from the other side on a sagittal. So this is now from the other direction. Again, you can see a change in shape of the meniscus. You can see here this family of bone cysts or dead bone here, mama or dad, mom, and the kids over here. And again, can't find those same huge cysts on the cuts on the 13-month after slices. So whatever was done to that meniscus clearly impacted what was happening in the surrounding bone, which is what we wanted to see. This is a woman who tripped over her dog, was a news personality, tripped over her dog, actually ended up losing her job as a newscaster because of some of these things that happened. And you can see here, this is her talus, this is her tibia. You can see the gray cartilage in the talar dome area. That light area and all this stuff down here is bad. And you can see here after treatment where you get a normal appearance of the cartilage on a 3-Tesla MRI. You get a normal bone cortex and then a normal talar dome bone signal through that area. We also have treated patients with bony non-union and have a number of those. This is an interesting one here, where this is another woman who tripped over her dog. Seems like a lot of people tripping over dogs, but a different one. And you can see here she's got a very big fracture. This is 9 months after she failed a bone stimulator, after this ORIF that they put in. They were about to back all this stuff out, re-break the area, bone graft it, and re-instrument it. So a huge second surgery for this woman. All we did was to inject her own mesenchymal stem cells via a needle into that fracture line, and that's 5 weeks, and that's 14 months. So within 5 weeks, we're already seeing bridging of a 9-month-old fracture that they were about to basically reoperate.